So I'm going to speak about kinematic alignment in knee replacement and how we may be able to, I guess, define the new standard. This talk was going to follow the first talk on mechanical alignment, but that's okay. I'll just move forward. So knee replacement has evolved from the early days when the implant was everything, from the Freeman Swanson through the IB2 and then into the total condylar knees. From the 1970s really through to the 1990s and 2000s, the implant was what it was all about. And we used standard instruments to achieve implant alignment and fixation. But as the first part of the 21st century became evident, we got to use more computer navigation technology and with that, PSI implants. And we became very focused on alignment and really seeking that 0-0 algorithm. However, in the last 10 years, we've seen robots come into the picture, and we're now having this debate, or if you want to call it the alignment wars and the rise of the robots, where we're really trying to consolidate the issue of alignment with soft tissue balance. And I think that's the recurrent theme that I'll be referring to. So I want to make it very clear that alignment does not equal balance, and a long-term knee replacement needs both. So alignment, yes, it's important, and balance, it's very important, but to get a good long-term happy knee, we need both. So for those of you who are very strong disciples of mechanical alignment, and I'm not critical of that, I just ask you to understand what version of mechanical alignment you are delivering. Do you do measured resections? Are you a gap balancer, or do you do a hybrid version? And how are you achieving that? Are you using mechanical instrumentation, the standard instrumentation, patient-specific implants, or are you navigating? And after that, how are you verifying not only your alignment, but your balance? And I would ask you, are you sure you're delivering what you set out to do when you go for 0-0 mechanical alignment knee replacement? So kinematically aligned total knee replacement is really an evolution of anatomic alignment, which was promoted by David Hungerford back in the 1970s. And there was really a divergence of opinions about which way was the right way to go. The problem with the so-called anatomic approach at the time was there were issues of sizing, accuracy of osteotomies, and that resulted in a moderately higher failure rate. And that really meant that the Insel philosophy of going for 0-0 mechanical alignment with soft tissue releasing became the predominant algorithm. The debate restarted, I suppose, when Bellemans published his landmark work showing that, you know, really not everyone is aligned in neutral. Not everyone is at 0-0 mechanical axis. There's a variety from varus to valgus of constitutional alignment. And those concepts have been further refined more recently by Sam McDessie in his group from Sydney, using this new term called the coronal plane alignment classification, which really combines preoperative analysis of pre-disease alignment and joint obliquity, and in doing so, trying to predict how to balance and align our knees more specifically for patients. So why would we consider a change? Well, back in 2005, Eckhoff demonstrated that the tibia does not rotate around the transepicondylar axis. It rotates around the femoral condyles, both medial and lateral, and that's not exactly the same as the TEA. So if we're not aligned in neutral, as Bellemans has shown, and we don't rotate around the TEA, we must either often need soft tissue balancing or be unbalanced through the range of flexion, or both. And remember, it was John Insel who did say that we may need to recreate a patient's individual anatomy to get a balanced knee. So that implied soft tissue balancing. So what is kinematically aligned knee replacement? Well, it aims to correct the arthritic deformity of the limb to the constitutional or pre-arthritic alignment of the patient. And it does that by trying to restore the natural tibiofemoral articulation, alignment, and soft tissue laxities, including joint line obliquity. What it is not is just putting the tibia in a little varus. Probably one of the most commonly held misconceptions about kinematic alignment is that, if I just put the tibia in a bit of varus and then do the rest of the operation as I would normally do, that's kinematic alignment. That is not what it is. It is performed differently. It can be performed in a number of different ways. You can use patient-specific jigs, as was originally done with the Otis Med group when Stephen Howell started doing this. You can use modified conventional instruments, which I have used and moved on through. You can use computer-navigated protocols, and more recently, we're using robot-assisted technologies to gain an outcome. So it aims to restore the three axes of alignment: the transverse femoral axis, about which the tibia flexes and extends, which is the Eckhoff axis; the transverse femoral axis, about which the patella flexes and extends, which is a little bit more anterior and superior; and the longitudinal axis, about which the tibia internally and externally rotates. And that's what we're trying to reproduce. There are a number of assumptions or preconditions that you need to be aware of. The cartilage thickness, the assumption that we make is that the cartilage thickness is 2 millimeters on the femoral side. So if we're making any resections where there's been full thickness cartilage loss, we account for that by adding 2 millimeters. We assume that the tibial cartilage thickness is somewhere between 2 and 3 millimeters, and that's a little bit more variable, particularly on the lateral side of the tibial plateau. It's important to understand kinematically aligned knee replacement is suitable for patients where there is no major ligament disruption, that is, stretched ligaments. So if you've got a severe varus knee with terribly stretched lateral compartment, lateral ligament structures, then a KA knee may not be suitable. But it is worth noting that we don't really believe that ligaments contract. They do bend around osteophytes, and the osteophytes need to be removed, but the concept of ligament contraction is questioned by those of us who pursue KA knee replacement. So when I learned kinematically aligned knee replacement, I learned using modified instrumentation as per Stephen Howell's technique. He's very clear on measuring tibiofemoral offset and performing a distal femoral and posterior femoral resection that is essentially a resurfacing. And it's very important to measure your offcuts to make sure that you are going according to the plan. Once the femoral resurfacing is undertaken, you define your tibial rotation along the long axis of the lateral tibial plateau, excise all the osteophytes, and obtain flexion extension balance by modifying the tibial osteotomy if required. So the order of planned resections is very important. The first resection is a distal resection from the femur, accounting for cartilage wear. The second resection is an equal resection of the posterior condyles without external rotation of the femoral implant. And the third resection then is of the proximal tibia in the line of the natural medial proximal tibial angle. And if you perform those resections appropriately, then you are likely to get a well-balanced kinematically aligned knee replacement. So again, just to re-emphasize that the resection on the distal femur is equal, accounting for cartilage wear. So if you've got a worn knee where there's a complete medial compartment articular wear, then you'll resect, say, 6 to 7 millimeters of bone and cartilage. And on the unworn side, you'll resect 8 to 9 millimeters, depending on the thickness of your implant. And similarly, the posterior resection is equal. Where kinematic alignment with standard instrumentation gets interesting is that it's the tibial osteotomy that balances the knee. And so you do need to be aware of some limits on how much varus you will put on the tibia. But what you're aiming for is equal gaps in extension and slight lateral laxity in flexion. The balancing is done by minor adjustments to the tibial osteotomy and very rarely any soft tissue releases. What we're aiming to reproduce is the distal femoral valgus angle, the natural distal femoral valgus angle of the patient, and the natural medial proximal tibial angle for the patient. So this is just some very quick videos. This is the modified instrumentation that we used when I was using it, where we would accommodate the wear with a 2mm spacer to then perform our distal femoral osteotomy. Then we would go about and perform our tibial osteotomy and making sure that we got our rotational alignment preset before we actually made the osteotomy. And then we would use a conventional instrument and usually, not always, but usually put a little bit of varus onto that tibia. And then we would make the cut. And then we would make our assessment of all of the balance as we would normally do. Now, our first 100 patients we looked at to make sure that we were not going crazy with this operation. And this was the distribution of mechanical axis for about 89 of those patients, first 89 patients. And you can see that over 82% were within plus or minus 3 degrees of the mechanical axis, with many of them neutral to 0. So we were not putting our knees in crazy positions. The amount of tibial varus was on average 2 to 3 degrees. So that implies that our 2 to 3 degrees of tibial varus was being accommodated with 2 degrees of femoral valgus on the other side. And we've had no failures of those patients for loosening or infection. Stephen Howell has published a very comprehensive algorithm for how you balance the kinematically aligned knee replacement. And I won't dwell on it. It's well published, and I would urge you to go to the literature and have a look at that. But as time has evolved, so has the way I've performed these operations. And now that we're getting greater access to robotics and computer-assisted soft tissue analysis, and more importantly, as the broader orthopedic community has come to take on these newer concepts of alignment and balance, we've defined some boundaries. And so it's now being generally accepted that up to 6 degrees of distal femoral valgus and up to 3 degrees of distal femoral varus are the limits. And on the tibial side, it's reversed. So 6 degrees of varus versus 3 degrees of valgus. And we're still, however, looking for overall alignment of no greater than 6 degrees of varus or 3 degrees of valgus. And so now that we have our assisted technologies, we can be much more precise in the way we perform our KA knees. So this is just a brief example of the way I'm doing many of our KA knees, where we're using some assisted soft tissue balancing devices. We recently performed a study comparing femur first KA knees with tibia first gap balanced knees using the same technology. And the interesting thing is what we found was that our normalized laxity profiles between 2 different surgeons doing 2 different techniques, but using a gap balanced protocol for the mechanically aligned knees were very similar laxity profiles. So we're not getting bad imbalance. We're in fact reproducing excellent balance. But what is different between the 2 groups is that the femoral rotation is much, in the KA group here, is very closely centered around just being very parallel to the posterior condylar axis, whereas there's a great deal more variability in the femoral external rotation in the gap balanced group. This slide shows really the effect of the difference between a KA knee, these 2 boxes, versus a mechanically aligned knee. This represents femoral valgus and this represents tibial varus. So we're reproducing the patient's joint line obliquity, whereas in a standard mechanical knee, we're getting a much more horizontal joint line. But interestingly, our overall pre and post-op alignments of the mechanical axis are actually very similar. So in the 2 groups of patients we looked at, we had pre-op broadly varus knees with a variety, and we've, in both groups, both the kinematically aligned group and the mechanically aligned group, obtained very satisfactory overall mechanical alignment. So we're not putting these knees in terrible mechanical varus. We're actually reproducing the patient's joint line with very similar alignment profiles. So that's just a really very brief discussion around kinematic alignment, but what it really is it's a femoral resurfacing and then allowing a tibial osteotomy to balance the knee back to its constitutional alignment. I'd encourage you to read widely and be not jumping in and doing crazy cases. Do selectively early cases and understand the limits, but also understand balance and alignment are critical. There's a few unresolved questions and we can discuss these later. It's whether recreating natural joint line ubiquity is good for patients. There are issues around the patella, which we might have in the discussion. We certainly have a much lower soft tissue release rate. We think that's good for patients, but it may not be. And maybe we need new knee design to accommodate the new implant alignment philosophy. So they're all things that we could discuss at a later stage. Thanks very much for your attention.